Good morning, everyone. Welcome to this session on community engagement for health emergencies and integrating lessons learned from the COVID-19 pandemic, organised by the European Centre for Disease Prevention and Control. My name is Nick Fahy. I'm a senior researcher at the University of Oxford and expert advisor to the European Observatory on Health Policies and Systems. And it is my pleasure to be moderating today's discussion. We will be welcoming a broad and very distinguished range of speakers to discuss this topic today. I think that we've all seen during the pandemic the importance of communities. We've asked so much of our communities during the process of this global health emergency to change how we behave, to support each other during the pandemic, and to take steps like vaccination, and like changing workplaces and other adaptations in response to this threat and to the interest not just of ourselves or our own communities, but of our overall community as a whole. And so this session is an opportunity to explore this issue of community engagement, why it's such a challenge, and how it can be done best, because again, I think we've all seen during the pandemic examples of excellent community engagement and perhaps ways in which communities that we're familiar with have not been engaged as well as they could have been. I'll introduce each of the speakers as we go through today's session. It's going to fall into two parts, and an initial introduction, a focus specifically on the outcomes of the COVID-19 pandemic, and then a broader session on the challenges from health emergencies more generally. You're very welcome to take part in this session by putting questions using the Q&A tab throughout the session to put questions to panelists, and I'll draw on those in terms of the questions that I put through to people. We're going to give you an opportunity later on as well to provide an input specifically that will, in the midpoint of today's discussions, to give an opportunity for you to engage with this topic directly and to help us steer the second half of the discussion during today's session. What I'd like to do first, though, is set the scene, and I'm not going to do that. I'm going to turn to a far more expert speaker, John Kinsman, who is a behavioral science advisor at the European Centre for Disease Prevention and Control. And I'd like to turn to John now to invite you to give us an introduction to this topic, and to tell us about what we mean by community engagement, why it's important, and what are the lessons that we have learned from the current pandemic. John, are you there?
Thank you, Nick. I am here, and good morning, everybody. It's a real honor to have the opportunity to open this and provide some initial thoughts on the topic of community engagement. Thank you all for being here, and also very, very special thanks to all the panelists for joining us today. Community engagement is, as Nick said, is an issue which has been very much present during the pandemic. What do we actually mean by this term? I would describe it as essentially a process in which national or regional or local authorities are working in partnership, and the partnership is the key word, with groups of people, communities, who are at risk of or currently beset by an outbreak of an infectious disease. So in other words, it's about listening, it's about dialogue, it's about understanding what people's concerns are, what their expectations are, what their needs are. And I think it's quite clear that in any public health emergency, the strategy and the approach needs to be directed by the public health authorities. I think that's very clear. But it can't be just a case of people saying, this is what you have to do. If you go down that road, or a sort of top-down approach, you won't necessarily be speaking to people in a way that will be meaningful and attractive and appealing to them. So community engagement essentially requires that you understand what people's thoughts are about the the disease in question, what their thoughts are about the response to the disease, and to address those and to meet them in the terms that they would recognize and understand and appreciate. What do we mean by community? Community is a relatively elusive term, but I think for the purposes of our discussion today, we could describe it as in two ways. On the one hand, if you have a president or a prime minister who's speaking to the country, you're speaking to everybody who is Estonian, everybody who is Polish, everybody who is Spanish. So that element of your identity, which is national, would be part of that community. So the community in that sense would be all the people in the country. But we could also think in terms of a community as being a particular subpopulation which has particular concerns and risk factors associated with the disease. So you could be thinking, for example, in terms of elderly people, or people who have challenges with mobility, or pregnant women, or migrants, or other ethnic minorities, or people experiencing homelessness. You can see the list is long. Now, each of those different communities have very particular concerns. Think about the issues of a pregnant woman as compared to the issues of an elderly person. These are not, then you can talk to them on one level, in generic terms, but equally, specifically, they will have different issues that they're worried about and they're thinking about. So these communities need to be understood, and their concerns need to be addressed in a way which is meaningful to them. If you don't do this, you're essentially shooting in the dark. And I want to take you back very briefly to the Ebola outbreak of 2015 as a very clear example of community engagement. I think possibly one of the clearest you can think of. The outbreak there was amplified by unsafe burials. People have a very culturally important need to bury people in a certain way, which involves washing, which involves certain very physical issues to do with the deceased's body. And of course, this can create conditions where the Ebola virus can spread very easily. So this was an amplification of the epidemic, which really needed to be addressed. But it had to be done in a way which was acceptable to the population. The authorities there came down in a rather heavy-handed way, took bodies, buried them without allowing any of the cultural rites. That was not a good community engagement approach. And people then literally dug up the bodies and went through the process and reburied them in the proper way. So the community engagement required listening. What is it that you need to do with the body? How can we do this in a safe way so that the cultural rights are respected, so that the spirit can be released, and so that the people can be kept safe? And this actually, once this was worked out, the epidemic was to a large extent brought under control. So that's a very, very good example and a clear example of how community engagement can facilitate addressing an outbreak. But with COVID, of course, it is infinitely more complex. We have so many different elements, so many different factors, so the whole process is that much more difficult. And we've seen that with issues to do with face masks. We've seen that with issues to do with vaccines. So the complexities of all of the different communities, all the different concerns that people have, and all of the different array of interventions that we need to implement to control COVID make this a much more complex issue. Nonetheless, I will say there has been a lot of progress over the course of the pandemic at ECDC with civil society groups who are working with socially vulnerable populations. And we have seen they're reporting to us that there has been much more engagement by authorities as we've moved through the pandemic. So there has been progress. And I would say that if we're going to be making a call for where we should be moving forward, I would hope that we can actually institutionalize this much more into preparedness and response activities, so that community engagement really becomes a core part of the activities of the authorities. Memories are short. The next crisis will be just a few months away. And when that happens, everybody will move on. So we need to implement this now. We need to institutionalize this now. And that would be my call. So I hope that provides at least some food for thought. This is a huge topic, of course, and there are many other elements that we could discuss, but that just gives a short oversight of some of the issues that maybe we could discuss further during this meeting. Thank you.
Thank you, John. Thank you very much for that short introduction. And You've emphasized the importance of partnership, of dialogue and understanding. And you were talking at the end there about institutionalizing this and really learning from it. Because I've worked in a government. I'm sure we've all worked in situations where there was an emergency, and the instinct is to be very top down. The instinct is to control, is to say, well, you almost do this. And I guess what you're saying is actually an essential part of this, of the response, is not just telling, but also listening, if I put it at its most basic level. And is that a fair sort of way of just a sort of a core summary, as it were, of the process?
Yes, I think that would be very well put. And I think the key thing here is about, this is an ongoing process. It's not something that you do and then it's done. It requires ongoing dialogue, ongoing listening, and it's premised on trust and it's premised on respect. And so this is a sort of a whole attitude that needs to be in people's minds as you're working with communities. So yes, I think you've summarized it very well, Nick. Thank you.
Thank you very much indeed. And I'm sure that those questions of trust and respect will come back to that in discussion. I'm sure those are themes that will return. John, thank you very much for setting the scene for us in this session. I'd like to turn now to our first panel discussion, and I'll introduce each of the speakers as we come to them. And the first speaker who I'd like to turn to is Sir Michael Marmot, Professor Sir Michael Marmot, who is director of the UCL Institute of Health Equity at UCL, University College London, and who is chair of the Commission on Social Determinants of Health. So Michael, John in his introduction there was talking about different ways of understanding what is a community, and about how some of those ways of understanding also refer to different vulnerable communities and vulnerable groups. And you have spent many years as the world's leading analyst of some of these factors of social determinants of health. Could you tell us, what are the social determinants of health, and how are they relevant to community engagement in our response to COVID-19?
Certainly, and thank you for including me in this. On the 30th of June, 2020, the front page of the Guardian newspaper had two stories. The big one was England 2, Germany 0. And the other one, filling the front page, was jaw-dropping drop in life expectancy. Unfortunately, the cliche jaw-dropping came from me, and it came from the report of Build Back Fairer in Greater Manchester that we had published on that day. The fall in life expectancy in 2020 in the Northwest region, of which Greater Manchester is a part, was 1.6 years for men and 1.2 years for women. I can see, Nick, your jaw just dropped. Your eyebrows went up. That is jaw-dropping. England 2, Germany 0 is jaw-dropping, but that sort of passed. We've still got to live with the 1.6-year fall in life expectancy in men and the 1.2-year fall in women. Park that for one moment. I talked to a lot of different disease-specific groups. I was talking to an international meeting of dentists, oral health, and I put up two slides. Both of them had deprivation on the x-axis. As you moved to the left, more deprived, to the right, less deprived, and both of them had some disease on the y-axis, and you see a gradient. And the gradients looked parallel. The greater the deprivation, the more of the disease. And then I put the labels on the graphs. One was COVID-19 mortality, and the other one was decayed, missing, and filled oral health in children. Identical gradients, identical. And then I was talking a bit later to the heart disease prevention people. So I showed those two graphs, and then I showed a third graph without a label, with an identical gradient. And then I put the label on, childhood obesity. Identical gradient. What's going on here? COVID's caused by a virus. Dental caries are caused by diet and poor oral hygiene. Childhood obesity is caused by, well, you tell me what it's caused by, but it's not a virus. And it's an identical social gradient. In other words, if we want to deal with the effect of this pandemic, yes, of course, we have to control the virus, but we have to deal with the causes of inequalities in health, the social gradient. And that is the social determinants of health. And working, John said at the beginning, a community could be a country, but if the national government isn't paying attention to the causes of inequalities in health, then we need to work at a different level. And we were invited in, firstly, Coventry in England declared itself a marmot city. Greater Manchester said, well, if Coventry can be a marmot city, Greater Manchester can be a marmot city region. And we had started working with them before the pandemic struck. But then the work obviously was very much affected because the pandemic exposed the underlying inequalities in society and amplified them. So the 6 domains of recommendations that we had identified in my Marmot review: early child development, education, work, employment and working conditions, having enough money to live on, healthy and sustainable places and communities, including housing. And the 6th is behaviors, taking a social determinants approach to behaviors. Those were all exaggerated, both by the pandemic and by the response to the pandemic. Take education. Lockdown, closing the schools, increase the educational divide. How are you going to work with communities if you ignore the fact that poorer children are suffering? It took a footballer in England to get the government to change course on feeding children. The government said it is okay for children to go to bed hungry, until a footballer said, that's shameful. You really ought to help feed children and reverse your policy on free school meals for poorer children. So if I go through those 6 domains, the pandemic and the societal response to the pandemic exaggerated all of them. So in working with Greater Manchester, we worked right across the patch: city government, regional government, health and care system, community groups, the third sector, voluntary and community groups. And it was vital to work right across the patch. But that doesn't let national government off the hook. If you say to people, you know, you've tested positive, you've got to go and isolate, and then they lose money. They can't afford to feed their children if they go and isolate. So if you don't give the proper economic subsidy, how are the communities supposed to react? And so what the pandemic showed us is all the social determinants of health that I've been pushing for a very long time got exaggerated. And if we really want to control the pandemic and its effects, we have to pay attention to the social determinants of health.
Thank you very much. It's such a powerful message to start with, and the image of those graphs and the parallel gradients between conditions which on the face of it, you wouldn't say had a similar causal mechanism at all, but what your work shows is that underlying them is a very similar set of causal mechanisms in the form of the social determinants of health. You've also talked about this engagement, and for those people who aren't familiar with the UK, both Coventry and Manchester, to be honest, Sir Michael, we have depressingly high levels of inequality across the whole of the UK, but you would say that both Coventry and Manchester would be among the areas with greater concentrations of poverty and people in at lower ends of the socioeconomic spectrum. You've also talked about a way forward, a different type of working together. What would you say were the advantages for you? Because we always focus on the national governments and they have such powerful levers at national level. What were the advantages of working with these localities, with these communities?
Well, national government action is vital. As I said, we can't let national government off the hook. But the advantage of working at local and regional level is that both the local politicians and the services are much closer to the reality of their communities. I've found working at the city level that the political party to which the local politicians belong matters less than it does at national level, because local politicians really understand the conditions in which people are born, grow, live, work, and age. In other words, they understand the social determinants of health. They're responsive to their local communities because they live there. They're part of it. That's the people they deal with every day, quite apart from if they're politicians, the people who elect them. So the advantage of, and in a place like Manchester, there's real civic pride. There's a real sense of belonging. I'm pleased to be part of this city, people say. You know, I'm Mancunian, I belong here. And even within the 10 local authorities that make up Greater Manchester, there's great pride of belonging to Salford or to Trafford or to Manchester City. There's great pride. And so working with communities, tapping into that civic pride, tapping into that local understanding of the conditions that are impacting on people's lives, I think makes it more possible to make progress.
That's very helpful. Thank you very much. And I think we'll draw on that as we continue the discussion. So Michael, thank you very much. You've talked about that the importance of that sense of place. And I want now to turn to Reem Musa, who is humanitarian advisor on forced migration at Médecins Sans Frontières. I guess, therefore, Reem, you're familiar with working with people who have been removed from that kind of that sense of place and removed from that locality. And I'd like to invite you to tell us about what have been some of the specific challenges faced by people in that context, for example, housed in migrant detention centers during the COVID-19 pandemic, and how have those been addressed? Over to you, Reem.
Thank you so much, and thank you to John and Michael already for highlighting a lot of the, I think, working with communities, and then especially when working with vulnerable and excluded communities, I think we've all seen the similar patterns, similar issues over the pandemic. And that is that this pandemic has only deepened existing structural inequalities, exclusion, and neglect that we've seen in our health systems and societies. For migrant communities, whether they are on the move, undocumented, even established migrant communities, so people from culturally diverse backgrounds, particularly those that live in low-income settings, what we saw was that they were very early on in the pandemic, what we saw is that they were more exposed to the risks of transmission due to COVID, but they were also exposed to bearing the brunt of the consequences of the COVID-19 measures, such as lockdowns, travel bans, and suspension of essential services. Additionally, migrant communities often were further stigmatized and used as and the pandemic was used as an excuse to implement further restrictive migration control measures, and used as an opportunity for states to conflate migration control and public health in many, many contexts. As MSF, we worked in 30 countries around the world, particularly on issues of migrants in the COVID pandemic, but in Europe especially, we worked in several different types of contexts, ranging from informal contexts to closed contexts in places like Portugal, France, Greece, Belgium, and the UK. And what we saw was a pattern, and we saw the pattern was that oftentimes migrants, particularly those that are the most at risk or vulnerable, were not even considered in COVID-19 responses, and particularly were not considered as a key group for community engagement. And those social determinants that Michael spoke of were often neglected and used as a point to stigmatize groups, particularly for those living in informal settings. And I would say there was a lot of overlap as well with homeless people and other groups on that, in terms of what we saw was roundups, the closing of shelters, people left without the means to protect themselves from COVID-19. But also when they required things like isolation and protection, they had no place to go. So as MSF, working in epidemics such as HIV and Ebola, and I think John already covered this, is that we've all learned that community participation, whether that's a kind of fractured community, you can take the time, again, it's willingness, you can take the time to map and understand where people live, in terms of designing responses, but also trust building are essential in any humanitarian response. Also essential is the removal of punitive measures and the fear of seeking help, which oftentimes for many people, particularly those that were undocumented or face administrative blocks for various reasons, it was often a barrier to care for them. As MSF, what we've done is that we've invested in community consultations, but also in peer-led initiatives, and really focusing on culturally adapted health promotion that is co-constructed and co-created with community members, but also pushed for the implementation of clear firewalls or clear separation between health services and police interventions, also for lockdown measures, but especially for immigration purposes. For example, in France and Belgium, we established shelters for undocumented migrants, but also those in transit and homeless people with COVID-19 to safely isolate and provide care for them when they had mild symptoms, in a place where they can have access to proper health monitoring of those symptoms, particularly in the first wave, as well as establishing mobile clinics to maintain access to services and ensure that proximity. And that's essential because it enabled us to build trust, but also show that through the proximity, through going to where people are, that non-punitive approach to COVID isolation and community health measures was very important for people to feel safe, to also reporting that they have those measures, often living in very densely populated places. Also, what we did, we invested in a lot of two-way kind of communication, digital health promotion platforms, whether they were on WhatsApp or Facebook, in diversified languages. And these were platforms that had someone on the other side, and not just medical workers, but also mental health specialists, also caseworkers. And a key part of this two-way communication was enabling people to ask questions, to share concerns, but also to ensure that we could act as a bridge to the other services that were shut down and people were excluded from, such as information on asylum and protection, which oftentimes was a key factor for stress in many groups. Another example is in Portugal, where we worked with, in Lisbon, with various neighbourhood groups, particularly for those who were African descendants, that were oftentimes stigmatised in the media and local press about their ideas of them being areas where there was high risks of transmission, that people weren't following the rules, all those kinds of things. And we know, we've seen in many places that those are oftentimes the people that keep our countries and our economies going, and therefore are often more exposed. To work on the co-creation of health protection models and mental health models that really focused on community assets and community strengths, and that's often something that is neglected. Oftentimes in closed settings, such as Europe's hotspots, detention centres and reception centres, what we saw was that lockdown measures and other measures, restrictive measures, were implemented in a harsher and more discriminatory manner. We saw that mass quarantine was implemented in many camps whenever there was a risk of outbreak, often for the benefit of keeping the disease inside, but further exposing those inside to COVID-19 measures, with little effort to actually apply protection and shielding measures of those that are most vulnerable inside these detention centres and hotspots. Many of these measures are still in place because they, as I said, it's the public health rationale of these measures is questionable, and we also know that there's interest to further contain some of these settings. As MSF, what we tried to do, especially because communities were even further isolated because the little contact with services they had was cut off, is really try to maintain that link. And for us, we found that those digital health platform means acted not just only as a digital health platform, but also was a platform to link people to services, as I mentioned earlier, but that two-way feedback, which enabled us to monitor conditions inside, but also co-design tailored approaches in the app and the outbreaks, such as distribution of masks and hand washing points. To wrap up, because I can see that Nick is putting his hands up, for us, I think what we've learned is, and what we know is that migrants and refugees and undocumented people must be included in national and global responses. We need to ensure health access for all and health equity as all, as Michael has already highlighted, and that a punitive approach doesn't work when you're trying to develop a public health response.
Thank you so much. Reem, you've already, I had like 2 questions I was going to ask you as follow-up questions. You've already answered them. So you talked about the specific challenges of this community, about a lack of engagement by the receiving communities with these migrant communities, but also about some of the, and you talked about some of the ability of the migrant community to act as a community of its own, and about some of the variety of tools and platforms of engagements that you've engaged with, and that's really, really helpful. I have one, but super quickly, if you wouldn't mind, and if you say this needs a much longer answer, then we'll see if we can come back to it later. To what extent have you seen a kind of a solidarity between communities, so between the migrant community and between the community of the host country? And is there any way of facilitating that, do you think? Is that something that's been happening, or is that not a thing we should be looking at?
I think that's a very complicated thing. We can have a conversation about that one day, I'm sure. But I think what we have to start with is that migrant communities and host communities are not a binary, so I think that is, we live in these complex, diverse societies. And I think if we start there, I think also our national planning, our local planning, and our understanding of the societies will be much more true to who we are, and actually be able to respond to the diverse communities that we live in. What we saw during the COVID outbreak is that actually the imagination that we have of community isn't actually reflective of the societies that we live in. For example, the example I gave you in Portugal, many of those communities of African descendants, some have been there for a few months and some have been there for many generations. Yet actually those social indicators that Michael spoke of in those neighborhoods were very similar, regardless of the duration of time someone had been in the country. Oftentimes, people's understanding of Portuguese was different, but many of these people come from Portuguese former colonies, so have a sense of Portuguese. But it was more about what is the willingness to tailor responses to them? What is the willingness to reach out to them? And what is the willingness to see these communities as a part of the societies that we live in, and a valued part of the societies that we live in? So I think that's very important. For communities that are in closed settings or people on the move, I think there's a massive solidarity across Europe, which is very important. But what we are seeing is more restrictive measures from governments that also limit the space for solidarity for a lot of them.
Thank you. And my apologies for asking a really complex question and then asking you to answer it really briefly, but which you've done, which is really great. And I think, so John said right at the start about how, like, part of our challenge is about how can we institutionalize these things. And I think, so Michael already outlined many ways that he's been working with colleagues. I think for me, one of the things that comes out of that is one of the key routes to institutionalizing this is for us to start from that sense of diversity. And for authorities to start with that, to have an understanding of our communities and our societies, which recognizes the variety and the diversity within them. I'd like to turn now. So, Reem, thank you so much. You said actually early on that many of the issues, there was quite a bit of overlap with some of the challenges faced by homeless people. And it's a pleasure to turn now to Freek Spinnewijn, who is director of FIANSA, which is the European NGO working on homelessness and housing exclusion. And Freek, I think you might start by saying that you recognize all too many of these challenges, but what have been some of the specific challenges faced by people experiencing homelessness during the COVID-19 pandemic, and how have these been addressed? Over to you.
Thank you, Nick. There's only so much you can say in 5 minutes, but I'll try. So here we go. Let me first start by saying that we estimate that there is at least 700,000 people in the European Union and the UK that experience homelessness, sleeping in a shelter or on the street on any given night, and that's 70% more than 10 years ago. And that's just to say that we were already in a crisis before COVID hit us, and that's important to remember. What the challenges that we experience, maybe in general, you can say that the guidance to protect people against COVID didn't work for homeless people. Isolating as in your home is quite difficult if you're homeless. That's quite obvious to say. But more specifically, we encountered three major challenges. First of all, the living conditions of homeless people. It's clear that you're vulnerable when you live on the street. Many people live in shelters. 90% of the homeless population in Europe lives in shelters. Shelters are usually overcrowded. There's collective spaces, so they can be places where infections are easy. Night-only shelters, for instance, throw people back onto the streets every morning, and they come back in the night in a different bed. So you can understand that that is challenging in COVID times. That's the first challenge. The second challenge is the underlying health conditions. Most homeless people are sick, have poor health, poor physical health, poor mental health, addiction problems, etc. Just to give you a jaw-dropping statistic, as Sir Michael Martin did, we know that the average age of death for chronic homeless people, that move between the shelter and the street, is less than 50 years old. So it gives you an indication of how big a problem the underlying health conditions are. And the third issue is the disconnect between the social care and the health system. This is to do with problems of health insurance, stigma, discrimination, but also the wider issue of the fact that the healthcare system and the social care system, certainly when it concerns homelessness, function in parallel. Now, there is a number of solutions. And I'll go very quickly through them. One is that quite a number of member states have done a huge efforts to get people off the street, the rough sleepers, put them into hotel in safe accommodation. If you would have asked me 2 years ago, is it possible to solve rough sleeping? I would have said yes, but it will take years. But we have seen during COVID that if there is a sense of urgency and political commitment, you can do it in a matter of weeks. So that's quite important to say. The second is that in some countries, the improvement of the quality of shelter was an issue, like it happened. 24-hour shelter became the norm. Night-only shelter stopped because it's senseless anyway. More single rooms, more privacy in the shelter. The harm reduction approach was integrated in some of the shelters to capture those that would stay away from shelter, etc. And also, important to say that staff working in shelters, they are used to work in emergencies. Homelessness is an emergency. I think the reason why the infections were not worse than they are is mostly related to the fact that the staff know how to deal with it, how to function in an emergency. And the third solution, and that's much less frequent, but still important to mention, is that some countries use the COVID crisis to move to housing-led solutions. So not manage homelessness in the shelter system, but move people into self-contained housing with support. That's, of course, the best solution. And the fourth is the ban on evictions. Many countries put bans on evictions during COVID. It's interesting to note that in some countries, that ban on evictions was actually imposed by public health agencies. In the US, for instance, it was the CDC who imposed the ban on evictions. But we have to put all these solutions with a caveat, because many countries are turning back these solutions. They turned out to be temporary solutions, so people are putting back onto the street, back into overcrowded shelter. And three very quick concluding points. One of the things that we learned from COVID is that, or that we noticed, is that homelessness is now considered a public health issue. It was not before, even if it was. It's now also a public health issue. And that comes with a number of opportunities. Also funding opportunities, maybe social housing as a social prescription. by medical professionals is not that impossible anymore. The second issue is that I do a call on the ECDC to consider homeless population as a target group in their work, next to the existing target groups. There is a lot of advantages doing that. And the last thing is a call to use the homeless sector, the shelter sector, as a partner, an actor in the provision of public health. We estimate that there is about 600,000 beds in shelter, and it's increasing every year. And most of the people using these beds are sick. And it's stunning to see that that system is not used or not sufficiently used for public health purposes. So that's what I wanted to say as quickly as I could. Nick, sorry for that.
Great. You've like Reem, you've covered everything that I wanted to ask, all in one amazing contribution. Thank you so much. And I think that you've underlined both the challenges which are there and the particular challenges of that community, but also the potential for change and the potential for this, if it's seen in a different way, for the responses to be there. And I think we've seen this disconnect between health and social care in many, many different ways. And so Michael, in his the range of issues which he identified, also identified a sort of an even broader range of topics which are related to this. Because we're slightly short of time now, so what I'm going to do is I'm going to have one very final sort of question which I'm going to put to each of you, and I'm going to do this in reverse order. And what I'm going to do is I'm going to take a question from the Q&A, in particular, Freek, for you and for Reem, and then I know because Sir Michael has to leave us at the end of this session, I'm going to give Sir Michael the opportunity to either answer that question or to give a more general statement. And the question from the Q&A is about vaccination. And so it's an immunization. And so I think in what you have, in many of your discussions, colleagues, what you focused on has been the sort of the duration of the pandemic, and in particular the initial infection control and the support to people who are dealing with their own cases of COVID and the transmission of the condition. But we're now in this phase where immunization is a challenge, and a challenge that affects different communities differently. So the question here is about, could any of this be addressed? Could it have been addressed differently in advance, and what could we do now, perhaps? And as I say, I'll come to you in reverse order to give Sir Michael a chance to give his sort of broader final thoughts. Freek, you first. How does this issue of immunization play out from your perspective?
It's like I had no time to to say anything about vaccination, of course, but it is a really important issue, and it takes time to reach vulnerable people like homeless people. So yes, of course, we should have thought of that early on. But I also would say that quite a number of countries have listed homeless people as a target group in their vaccination strategies. But still, they don't sufficiently do things about it. Even the European Union, it might be surprising for you, but the homeless population is actually a target group of the European vaccination strategy. But I have not seen any specific measure of the European Union helping member states to target that specific group. So it's necessary, but it's not happening. And it's a call to be a little bit more proactive on that.
Thank you. That's clear. If we had more time, I would ask you what could be done to more better target that. And perhaps if we have time towards the end of the session, I'll come back to you. Otherwise, it's in the Q&A. And actually, speakers, you can also, I think, respond also to type an answer. So if there are particular comments that you wanted to give, perhaps you'd want to give those there. Reem, what do you, from your perspective?
Yeah, I agree with everything that Freek just said, and maybe I can add to the what can be done. So in terms of what can be done, and something that's practically that many local Ministry of Health are doing, and MSF and other civil societies are doing, but just as we implemented these kind of proximity, trust building, outreach approach for general measures, that same approach can be taken for vaccination rollout. So we are working on mobile clinics with local health ministries in various countries to work on the vaccination, but also doing proactive outreach on health education, having health conversations with people, not even health education, to discuss fears and using as well those digital two-way platforms again. Important to add that it's not just people's fear of getting the vaccine. There's also the issue of administrative blocks, particularly for undocumented people and migrant groups, which are often an additional barrier to seeking the vaccination and vaccination care. And as Freek said, much is being said, little is being done. Much more needs to be done.
That comes back to your point about this I think you used the expression firewall between the sort of the services people that need to access and the police and border enforcement that people are, understandably very nervous about. Is that right?
Definitely. And for homeless public people who don't have an address, people filling out these forms of the appointments, the time, all of these kinds of things, it's not feasible. That's like basic information, right? So for homeless people, that's something that happened. And then for migrant groups, having the national ID number, all of these kinds of things to register for your vaccine, not possible. So often finding those other solutions, or also doing direct vaccine campaigns and having that vaccine campaign approach that we know works in lots of other countries around the world when we want to do mass vaccinations, kind of bringing some of those lessons learned into a European context. It's interesting because the easy measures that have worked in much more complex contexts, it seems that we don't want to adapt and take them on in the European context for various reasons because our health systems aren't built that way.
It's that institutional context is such a structural influence, isn't it? Reem, thank you. You also now you've been so interesting that there are now requests for more information about your work in the Q&A. So you might like to have a look at that, see if there's anything you can respond to in writing on that. Sorry, I know you didn't come here for homework, but I mean, there are people who are very interested in what's happening.
No, it's fine. I also can put in my email in the Q&A and people can reach out if they have.
There we go. So Michael, I'm going to come to you, and you have full discretion because you can't join us for the final session. If there are sort of overall, I daren't say if there's one thing, because of course, as you rightly said, there isn't one thing. When we were talking beforehand, what would you say now in terms of what would you want people to leave with as the key messages in these issues?
Let me respond briefly to your vaccination question, and then I'll respond to what you just said. Picking up what Freek and Reem said, I think the evidence suggests that vaccine hesitant people fall into perhaps 4 groups, and to do something about it, we have to understand the causes. And I think 3 of the groups we can address. The 4th is more difficult. The first is, I'm too busy. Vaccination doesn't fit into my life. And that obviously relates to migrants and refugees. It's just too difficult. The second is, it's not really for people like me. That's one of those interventions in the health system. I'm homeless, I'm a migrant, I'm some other marginalized group. And it's not really for me, it's for them. And again, we should be able to address that. The third is, I don't trust people in authority. I don't trust them. They've been doing all sorts of dreadful things. We know surveys show that nurses are trusted by 93% of the population. Politicians are trusted by 14% of the population. People don't trust politicians. So the politicians say, get vaccinated. People will say, I'm not going to do what that guy said. I don't trust him. And they've earned that mistrust. They worked hard to get people to mistrust them. They lie to us all the time. And people are right to mistrust them. So we've got to deal with that severe mistrust. The 4th group are the flat earthers. They think that Bill Gates is injecting a microchip in with the vaccine. And I don't know how to deal with them. We know that if you look at the US, by county, the higher the Trump vote, the lower the vaccine uptake. So if people are off with the fairies and they believe in God knows what, I don't know how to deal with that 4th group. But the other 3 groups, trust, logistics, having it work for people, we should be able to deal with it. And that leads to my response to your more general question. What we know in general, I was concerned about this in the UK, but it's more generally true. If you look at what happened to health in the decade before the pandemic, So in the UK, we had the slowest improvement of life expectancy of any rich country except the United States before the pandemic. And then we had the highest excess mortality in the first half year of the pandemic. And if you look more generally, the slower the improvement in healthy life expectancy in the decade before the pandemic, the higher the excess mortality during the pandemic. What's the link between those? I would say the link works at 4 levels: quality of governance and political culture. Second, increasing social and economic inequalities. Third, disinvestment from public services. And the fourth, being sick. Exactly what Freak said about the homeless. They're sick, they're at higher risk, not being very healthy. So what's the one thing that I would do? We have to put equity of health and well-being at the heart of all government policy.
That is an excellent note to finish on, Sir Michael, and I will thank you very much for doing that. Thank you to Reem and to Freg for being here and for contributing so actively and for making such clear points in such a concise period of time during this first panel. I'd like to thank you all very much for participating and for your contributions. I can see from the response from the participants that it's engaged very many people, and I'm very grateful to you. With that thanks, I'd like to draw this first panel session to a close. What we're going to do now, Cara, if you and your colleagues in the forum would be so kind, is we will have a break, but an active break. So we're going to have 2 word cloud questions, and this is the first one. What do you think is the main barrier to implementing good community activities, including for socially vulnerable populations like the migrant communities, the poorer communities, the homeless communities that we've discussed in this session? And then in a few minutes, we'll move on to think, what do you think is needed most in order to facilitate good community engagement activities? You don't have to immediately pick up on Sir Michael's closing remarks of putting equity of health at the center of government, but I know what I would put. So I will we'll leave you now for just a few minutes to both to perhaps put in your answers on this, to step away from the computer for 30 seconds just to stretch, and then we will come back for the second part of this very enjoyable session. Thank you. Thank you, everyone. We have some clear messages there, I think. So we have some clear messages from the second poll. Gashtai colleagues, is it possible for us to see the results also of the first word cloud question? What do you think is the main barrier to implementing good community engagement activities? Well, there's a lot of things there, isn't there? But the lack of political will, and I think it's very hard for me to think past Freg's example of, we used to think that tackling homelessness was a 10-year project, and then it happens in weeks. So that lack of political will, mistrust, which underlined by John, funding, ignorance, and a whole wider set of issues. And what, in a sense, what do we do about it? The second word cloud question, if we can see the results of that. What do we think is needed? Funding civil society, walk the talk, do what we say we're going to do, education, trust building. So it's interesting. This really underlines the message, I think, of we need the hard actions, we need the funding, we need the action, but we also need the trust and the engagement and the relational work. So perhaps, colleagues, if we now turn to the second part of this, so as we move on to think about community involvement in pandemic preparedness and response during health emergencies, the lessons we've learned and the way forward. Again, I'm delighted to welcome the 3 outstanding speakers who we have here before us, Andrea Amann, Inge Neven, and Christiana Oprea. I'm going to turn first to Inge, if I may, who is preventive medicine and COVID crisis manager for the Brussels government. Inge, we've had some fascinating messages from the first session. And I would sort of summarize them as, so Michael talked about underlining the importance of equity, but then also Reem underlined the importance of diversity. So equity doesn't mean treating everybody the same. It means recognizing the definition, the variation and the differences within our different communities. John talked about the importance of trust and respect, and underlining it, Freg talked about the importance of action. So how, knowing all of these contexts from specifically within the pandemic, how do you think can the uptake of COVID-19 vaccinations among socially vulnerable populations be optimized? And how can authorities such as the Brussels government work best with civil society and with other actors in order to address this? What would you say from your perspective from within Brussels, Inge?
Yeah. Yes, I think that everything that has been said is very interesting and very recognizable. So here at the Brussels region, we have 1.2 million people. But it also could be 1.4 million people, because we don't know how many paperless people are living here, for example. It's between 50,000 and 150,000. So we have a lot of migrants, a lot of also seasonal workers and people living for a long time here in the construction sectors and so on. We have a lot of homeless people as well, a big international community, and also, and that's actually the group I wanted to focus on, really a very poor community as well. So we are actually the second biggest cosmopolitan city in the world after Dubai. So with 170 nationalities and more than 100 languages that are spoken. And also with a poorer northern part, like a little bit as Manchester, like was told, with about 31% of the people in the Brussels area that are living below the at-risk of poverty level. So that's really a lot. It's 1 on 3 that are really at the risk of a poverty level. We have there also 40% of all people living in Brussels that don't have a general practitioner, so no doctor. So that's also quite a challenge, let's say. So, and we already saw it, and I think it was very recognizable what the people were talking about on the whole COVID approach. So it's not new for us, and I think that in the vaccination program, we really also tried to build up everything that we set up also in 2020 to deal with the COVID infections and clusters that we had. And so we really tried indeed to set up a very tailored approach for every type of target group, let's say, really to work really with the people of trust. So I think it's also something that came back already a few times, and it's really important that we always try to work with the organizations, and the people that have been talking here before are not unfamiliar to us, because they're very, very crucial to really work with the local actors and really people of trust to spread actually the messages. And we really see that unfortunately, indeed, despite all the efforts that we've been putting in place already, it's still very difficult to have this vaccination take up within this population actually. And it's indeed because the vaccination is not really on top of mind for the people. And they all have other problems that are much broader than only the health issue of COVID. They really are in having a lot of problems and so on. So what we really try to do is really to work very well with all these local actors and people of trust for every community, and really to try to set up a dialogue with the people living in these areas about their general situation. And then starting from that one, so to talk about what is their social situation, what is their household situation, what are the health problems, what are the economical problems, and so on and so on. And to start from there, and then to start to talk about the health problems, the impact of COVID, and then also about the vaccination program. But of course, and that's also quite an issue, there's a lot of pressure, of course, on, let's say, on all levels, because we're in the Brussels area, we are a little bit lagging behind in vaccination uptake compared to, for example, the other regions in Belgium. So there's a lot of pressure pressure politically seen to go quickly and to move quickly forward, because it's blocking, let's say, a little bit the other areas also to remove barriers like wearing masks and so on. Also in Brussels itself, because people want to have their freedom back, and it's blocking because the vaccination uptake is not quick enough and so on. And on the other hand, it's also very clear that is a process that is really taking time. We all know that to talk to people, to gain their trust, to talk about every issues, and to really go to the problem of COVID, and then to, let's say, convince them of the need to be getting vaccinated, and it's also it's safe and it's a good way to do it and so on. It's really very time consuming. It's taking a lot of energy, and it's also because people, it's not so easy to answer all the questions that the people have, and so you often also need really to train and to continue to train all the people that are in contact with these vulnerable groups, and because the information is changing quite rapidly, because we have new vaccines. It's new technology and so on. So, and the anti-vax messages that exist are very consistent since the beginning of the campaign. We always been talking about fertility problems. We've always been talking about indeed putting a chip in your arm and so on and so on. So it's really an issue of trust. And so indeed the government cannot bring these messages because we are not trusted. I think it's for sure. So we really want to work with these local organizations and people of trust, but it also means that we have to continuously to train them, and they don't feel confident themselves often because they also get very difficult questions. And so that's a little bit where we're most struggling with, to every time again giving the good information and finding the right people also to pass the information. So I think that's really something. So it's taking time, but it's moving on slowly. So that's that's one thing. And on the other hand, indeed, people want to go fast. So I think that's really something we're still struggling with. But things are moving forward. So I think it's really a positive point. And I also think, and that's something I want to close with, is that indeed actually it's also an opportunity actually for the future. If you look at the whole COVID pandemic, I think at least in the Brussels area, we really see that the whole local networks and so on that exist, and the access to the healthcare system and so on are very low. Like I was saying, 40% of people don't have a doctor and so on. So this pandemic is really an opportunity to set up local systems and access to healthcare also for all these people that were not having it before. And so I really hope that with everything that we are doing at the moment, both to make sure that the virus is not hitting too hard on the one hand, and the other one to really to increase the vaccination uptake. I think that the combination of both, and then putting in place local access for everyone based on their needs, that it's really an opportunity, and I really hope that we can build on it further on, and so to continue to build the trust that is really needed, and to have really equity and for everyone, starting from their needs and their point of view.
Thank you very much, Inge. And I think it's so important. There's sometimes such an image of Brussels as the capital of Europe, and therefore, you know, people have perhaps an image of Brussels as being some very, very rich, wealthy city. But as you said, I mean, the challenges are actually particularly acute in terms of some of the poorer populations. Purely for the sake of time, because there are so many questions I would like to follow up with on that, but purely for the sake of time, I'm going to move on now so that I make sure that each of you and Christiana and Andrea have an opportunity to make your contributions, and then we will pick up as we can. So if I may turn now to Christiana Oprea, who is Senior Consultant in Infectious Diseases and Head of the HIV Department in Victor Babeș Clinical Hospital for Infectious and Tropical Diseases in Bucharest in Romania. Christiana, there's a long history of engagement with people with HIV and AIDS in Europe, and that particular patient group has been perhaps one of the sort of almost defining patient groups for how one engages with a particular community. What lessons have you taken from that in relation to COVID-19 and perhaps ways in which this has informed how we could be approaching things better?
Good morning, and thank you very much for inviting me to take part of this very important meeting as a medical doctor. So I'm very delighted to be part of this meeting. And because working for more than 25 years in the HIV field and now coordinating the COVID-19 department since more than 1 year and a half. I think it's important, and I will start to highlight some similarities and some differences between HIV and COVID-19 pandemic, because we can start and we can first look at the statistics for HIV and SARS-CoV-2, and we know all that in 40 years we had around 75 million diagnosed patients with HIV and around 4.7 million deaths. But in the to date, for COVID-19, we have more than 232 million cases, and in 1 year and approximately 9 months, we have more than 4.5 million deaths. Of course, we are talking about an acute and a chronic disease, but there are a lot of similarities, and I think there are some things that we have to focus on, because there were, at the beginning of the pandemic, there were a lot of conspiracy theories related to HIV and now to COVID, that both viruses were created or leaked from the laboratory in Wuhan. And of course, we don't have to forget about stigma and discrimination and social isolation from the beginning of the HIV pandemic, that was called the gay plague. So of course, these things happened also with the cases of coronaviruses, at least at the beginning. And infection with SARS-CoV-2 is assumed to function in a tandem with multiple other health challenges faced also by people living with HIV, including HIV itself, but also other chronic non-infectious diseases, mental health disorders, substance abuse, alcohol abuse, and this HIV and these all other comorbidities may function synergistically to fuel COVID-19 disease in a syndemic, and interacting between these two viruses can produce an increased burden of both diseases in a population. And there are also other similarities, like the psychosocial implication, fear and anxiety related to disease transmission, that is for both diseases the case. There is also other important thing, that medical staff that was working in the HIV field was also involved in the treatment and the managing of COVID-19 patients. So these are the same people working with HIV and with COVID-19, at least in my country, and I think in most Central and Eastern European countries. And also another important thing is testing. Testing is important for both diseases, for HIV and for SARS-CoV-2. So testing is the word that we have to focus on. Because testing is limiting both infections and of course their effects on long term. Also, we have to focus also on increased risk, because there was discussion before, increased risk in immigrants that are more stigmatized and that they have less possibility to assess the health system in both related to both diseases. And don't forget about the short and long-term consequences and impact, not only on the health system, but also on the economical, social impact of both viruses on short and long term. And what are some lessons that we learned from this experience with HIV is that we don't have to overlook what was working and what was good in what we are doing related to the HIV pandemic. And at last, I have to mention also that at the beginning of the HIV pandemic then, community had an important role in moving things further in HIV. So it could have also an important role in the COVID-19 pandemic. So we have to engage and to have this community engagement, and maybe we could improve things. So
thank you, Christiana. And I think we've seen in particular, so one parallel which really strikes me, for example, is the community which is developed around long COVID, as it's referred to. So people with persistent COVID symptoms, where again, we see something where a little bit in a parallel to HIV, there was maybe the community in some ways was ahead of understanding the disease from where some of the clinicians were in terms of understanding.
And of course, we thought about an acute disease, but now we know after 1 year and more, and then 1 year and a half, that we have these consequences, this long COVID syndrome that is still there are still. This is in research, what is happening, why are these multiple syndromes appearing and like that. So it's not really an acute, it can be a little bit more, have a more impact on individual level. So, and on the health system, of course.
Thank you. And I have more questions for you, but I really, because we're a little bit short of time, I want to make sure that I go through each of the three panelists, and then I will come back according to how much time that we have. So thank you for now, Christiana. Andrea, may I turn to you? And the first thing I need to say is thank you, because it's the ECDC's initiative to organize this session and to bring all of these people together. And this has already been such an interesting and informative session. And I see that from the comments that we see from the chat. So I on behalf of the participants, I just wanted to say thank you to you and your colleagues for organizing this. We just heard from both Inge and from Christiana really sort of local level examples and about the importance of local level engagement. And then the ECDC, in a certain sense, is all the way at the other end as an international organization. How can international organizations such as yours contribute to ensuring that community engagement activities are actually institutionally embedded in these processes of pandemic preparedness and response? Andrea, over to you.
Yeah, Nick, thank you very much. And a big thank you to all the speakers because you have so beautifully filled the topic. And the reason why I decided to have ECDC's session this year in Gastein on community engagement is that I recognize it as one of the major key lessons from the pandemic. And I have said so in all the meetings that I have been since actually last year. And there has three aspects that in one way or the other have come out of all the contributions. For me, community engagement needs to happen with all society. To recognize that the society is a partner in the control efforts that we as health authorities have. That requires to understand their perceptions, their concerns, and their questions. Of course, the pandemic has highlighted the difficult situations for the vulnerable populations, but it has also shown that the normally not characterized as vulnerable parts of the society also needs to be engaged. And that, I think, is very important to carry on. Secondly, it became very clear that now into such a relationship in the pandemic under pressure is very difficult. So this relationship building has to start as in non-crisis time. And it has to be based on respectful listening and interaction and dialogue with the respective communities for all health issues. So that in the case of a pandemic or an outbreak, the specific issue can be easier transferred. Lastly is, I think it has to be an essential part of the preparedness plans. And this is why investment is needed. continuous investment, not just now. So what we have been doing or can do as a European institution that has actually nothing to say what the countries should do is we can give guidance, summarize what scientific evidence is there that community engagement is actually beneficial for the health authorities and the communities. We can see how this can be included in the preparedness plans with the involvement of the respective communities, of course. Secondly, we are working with capacity building. Capacity building part of the health authorities that are at the interface with the communities, but also on the community side with the NGOs, but also with influential spokespersons of these communities. And we are doing this now with webinars to certain topics. We had vaccine hesitancy, for instance, as one of the topics, where the countries can exchange experience, what worked, what didn't work, so that countries also can learn from each other. And lastly, that is something that we haven't been doing so much, but what I see as a task that we have to start is the advocacy, the political, so to advocate for the political will to actually make this funding and this investments available. So much to do.
Much to do, but also a very clear role for you as an international organization. So many questions, but colleagues, we have 9 minutes left of this session, and our Gastein colleagues will, even if we don't have beautiful coffee and excellent Austrian food outside the room waiting for us, they will still want us to finish on time. So what I'm going to do is I'm going to come to each of the speakers, and this time, if you allow, I will do it in the order that you originally spoke. So I'll come to Inge, to Christiana, and then Andrea, to you last, but also to give a sort of a framing. And hopefully, if we have time, I will ask for just a final word also from Reem and from Freek. But Inge, I wanted to, I'm so sorry, Inge, but I'm going to ask you a really difficult question. And my apologies, because it's not my question, it's come from the chat. Because one of the key issues here is about the fact that we're talking about building trust and relationship with people who don't have a lot of political power in the normal course of things. And that in many instances is, I mean, let's be blunt about this. That's why they don't have these kinds of big automatic relationships in the first place. How do we address that? Have you thought about that in the Brussels context? And as someone who's been doing this, how do you think about how we can somehow institutionalize engagement with these groups that don't have the same kind of automatic seat at the table or haven't had in the past? What do you think?
Yeah, it's a difficult question, of course, and otherwise it wouldn't be a question like this. But I think indeed we always have to find the few good examples, let's say, and to start working around them. So I think you always have people who are still showing a little bit more of interest and popping up a little bit. And I think that this is really the main opportunity somewhere that we have, that working with all these local organizations and working with all these people and so on, that you really can find some examples and that you really can work around them. But again, it's a very long process, and I think it's again a question also of having continuous attention, because I also think that something we learned here this morning, that it's not because maybe the pandemic will be a little bit better under control. I don't think it will be over soon, but under control, let's hope. And just not to give up the efforts, but really to continue to work in this way. And I think this is the only way to get a long-term, let's say, solution, but it never will be a full solution, but an improvement, let's put it that way.
Thank you. That's very clear, and it really speaks also to what several speakers have said about really institutionalizing this, you know,
Yes.
making this part of the long term. Christiana, I have a question for you, which again, it's a difficult question because you're talking to us from a hospital. We're very grateful that you've taken time out because you have a ward full of patients as well at the same time as you're talking to us. And I think probably if it's like many hospitals that I'm familiar with, some of the patients on your wards are people who could have gotten vaccinated and didn't get vaccinated because of these kinds of issues of trust and what some of the groups that Sir Michael referred to in terms of people who just don't believe, but you know, who, I loved his expression of the politicians have really earned that mistrust. How could we better reach patients, do you think? Perhaps building on the HIV experience, or more generally in terms of your understanding of the people who you're dealing with?
Yes, this is yes, a difficult question, a really difficult situation to handle, because most of the patients that are admitted in my department now are not vaccinated, of course, and they have severe forms or critical forms with need of oxygen tanks, or even high flow oxygen. So, and we start a discussion with them and we ask them, why did you have this hesitancy to get vaccinated? And we have so many different answers. Some of them have this mistrust in everything what was told by some politician, because they don't trust this politician. So they say, if they tell us to do that, I think we will not. And of course, there are a lot of conspiracy theories that are in the media, on TV, on some channels, and they are every day they hear something with negative impact on what they have to decide on for their own health. Only that it's an experimental, that they are put it in the subjects of an experiment, and like that. Others tell us that, of course, they have some health issues, like, I don't know, allergies, thrombophilia or something, and they are afraid of that they will take a risk by being vaccinated. So this is another category. And another one, at least today in the morning, I asked two of them, and they said, because we were stupid. This was the answer. Why are you not vaccinated? And they would say, because we were stupid. So it's really difficult to manage. But I think that a proper education, a proper message sent by healthcare professionals that are trusted by people, and a very sincere and simple explanation could improve. And because we now see a little bit an increase in the percentage of vaccination, slow, but we still see that. And because the result of the low percentage of vaccination in Romania was the what happened now with the fourth wave. So.
Thank you very much indeed. And this speaks to the need for these relationships of trust, which have to be built up over time, and addressing these different concerns in communities, I think. Andrea, I think we had such clear messages from the first panel as well about equity, about diversity, about trust, about political will. But there's also this question of time, of really institutionalizing this over a long period. What's your perspective on how best we can really do this? How can we take the messages that we've heard today and really try and see these taken up in practice?
Well, I think it has to be done at different layers. I mean, on the political level, but also at the public health authority level. And I think that the message that has to be delivered is that proper staffing and financing of public health so that it's really valuable for all groups of society is not just a cost, it's an investment. And that conviction needs to be created in those that provide this financing, because public health in the past years was the first area where governments often cut. And that is what we're paying for right now. So I think this has to be reinstituted as a investment, well worth the funding that you put in. And then, of course, we need to sit with our counterparts in the countries that are now revising their pandemic preparedness plans to make sure that these lessons are learned and institutionalized and taken care of for the future. I think that's, for me, the big opportunity that we have now.
Absolutely. That's a fantastic sort of closing message about this need to put that political will into the long-term investment in public health infrastructure and staffing and financing, and in a way that respects and engages with the diversity of all these different communities. I'm going to ask Reem and Freek, do you have any incredibly quick final comments that you wanted to make in addition to the comments that you've already made? Don't feel obliged. If not, then I will, what I'm going to do is I'm going to draw attention. Reem, I see that you're there.
No, I just wanted to quote someone in the chat, Elisa, when she said that I think this discussion for me has been super inspiring. So thank you to all the speakers as well. But yeah, remember that the concept of equity in public health is active words, they're not just buzzwords. So I think everyone in this discussion has shown how, when there's commitment and an active will to implement these things, a lot is possible.
Thank you. Yes, absolutely. I think it has been very inspiring. Freek, did you have a final word?
No, just to say that if there is any follow-up of this, we're available. If you are really serious about institutionalizing the cooperation with communities, we're there to help.
That's fantastic. And my thanks to you and to all the speakers, including to Michael, who isn't still with us, including John, who set the scene for us right at the start, Reem, Freek, Inge, Christiana, and Andrea, and an especial thanks, Andrea, to you and your colleagues for having taken the initiative to organize this session. My thanks also to the Gastein colleagues for, again, making a virtual session work so smoothly and so interactively. For those of you who found this as inspiring as we all did, you will see in the chat that there are several links to resources which have been put in there. Freek, I saw that, for example, you put in a link to some of the resources from FEANSA about how you see ways in which these issues can be addressed. And there are others in there as well. So hopefully this is a discussion which is also a link on to further engagement and further building. And I'm just going to, on that basis, thank everybody for taking part and wish you the very best in taking forward this highly important discussion and hopefully participating in other discussions within Gastein. Thank you all very much indeed.
Many thanks. Bye-bye.